Welcome back to the podcast, everybody. We're here doing a stat cases, which we haven't done for a long period of time. It was a series we introduced over a year ago now, and then COVID, as ever, gets in the way of lots of things. But today we're relaunching the series. We've got Katrina, who's going to talk to us about an interesting case she was involved with.
Yeah, so I met this young woman when I was an F1 on general surgery, and it was a night shift. And so she was a young lady, I think she was either in her late 20s or early 30s, with metastatic bowel cancer. I think they were still trying to actively treat it at the time, I guess given her age, and they progressed quite quickly. Anyway, she'd come in with probable bowel obstruction, which is probably a sign that her disease was progressing despite treatment. So she'd come into A&E, she'd got an NG tube placed, capnal by mouth, and giving her some fluids and things. And then while I was on the ward, the nurse said, "Oh, Katrina, her blood pressure's 60 systolic." And I was like, "Oh, okay, that's quite low." So I went to see her, we got fluid bolus in, and when I saw her, she looked sick. Like, I've never seen someone look grey before from hypotension, and I've never seen someone that young look that sick as well. I then called my reg, and I was lucky that day. I had a nice surgical reg who also wasn't like in theatre in an emergency overnight, so he could come up straight away.
The implication there being that not all surgical registrars are nice.
No, yeah, well, and maybe sometimes understand the gravity of the situation that you're trying to convey to them. Maybe I'll put that in. Maybe that's the more diplomatic answer. And he came up, helped me try and get a bigger cannula into her because she was so shut down. And it was the first time I ever saw someone try and squeeze fluids into a patient, which is, he's quite concerned too. But she, and this is probably the other thing, she was just really nice, had like a really nice personality. She was like cracking jokes, just had like a really nice personality. And I did my foundation in Newcastle, and she was like one of these classic Geordie girls who always had their hair immaculately done, fake tan on, fake eyelashes, makeup fully done. She had her nails painted, and we had to take them off for the pulse oximeter. You just really liked her. We got her some antibiotics, and we called the ITU reg to come and see her as well, because the blood pressure wasn't going to get any better with IV fluids. Now, looking back, now I've had like a bit more experience of people who are more unwell and people with advanced cancer. It's kind of surprising, but I'm glad they did that. The ITU team did accept her, and I think about it. So they accepted her for vasopressors. We finished our night shift, went home to sleep, and then I came in the next morning and I bumped into the ITU reg. So she went up to ITU, had some vasopressors, and I think the team came in the morning. She got reviewed by the consultant, and they kind of thought this is probably only going to go one way. But what they decided to do was they managed to get her a place in the hospice. They kept the vasopressors going so that she was stable to get to the hospice. She had kids, she had family. They also got someone in to do her makeup again for her, get her some clean clothes, just so that I guess she could feel a bit more human, and the stuff that was important to her, or, would just make her feel a little bit better, was able to be put in place. So, yeah, they transferred her over to the hospice. Her family and her kids could be around her, and then she passed away that day. I don't know how it's changed my practice. I don't know if I haven't been in that situation again. But I think there are a few reasons why it sticks with me and I still think about it. I guess one is that she was quite young and I'd never seen someone that young, that ill before. The fact that a lot of teams had to put things in place for her to get, we kind of have this phrase of like a good death, but lots of the stars aligned, like there was a place in the hospice, the ITU team accepted her, people thought, well, let's put this all together so that she can have this, which is not just important for her, but I guess important for her family and, her kids. It's much nicer to go to a hospice rather to come into a side room on a surgical ward to say goodbye to your mum. I guess it's kind of just highlighted to me how sometimes going that little extra mile for stuff like that can be really beneficial for family, but for yourself as well. It can mean a lot to you. I would always try and find out what patients' wishes would be and try and have those discussions earlier. I don't think anyone was planning that she was going to deteriorate that quickly. So the fact that we managed to give her a bit more time with some vasopressors so that we could put that stuff in place, and so her family could have maybe just a few more hours to get their head around what was going on. Just generally like a really rubbish situation, but maybe made slightly better by the team.
It's a positive story, isn't it? It's a positive case.
Yeah.
And if you're summarising that case, a lady in her 20s or 30s who died years before her time, that doesn't sound like it's going to be a good case.
No.
But actually, as you say, it's all those good things about the teams working together. It just makes that negative, that horrible situation suddenly not pleasant, but it makes it better. And it does make it good, actually, because that good death that she had, she was surrounded by a family. She's in the hospice, which is the best place to be. It's the best of a bad situation, I suppose.
The thing that's making me think about just listening to that is kind of what's really sad about now with COVID.
Yeah.
And that a lot of those things that made that story, the positives in that story and the things you're able to do, I think really sadly lots of people aren't having at the moment.
Yeah.
And I think, like you say, it does make a big difference, doesn't it?
Yeah.
And also, I just wonder, she was obviously young and maybe, people really have a lot of sympathy for that situation. I wonder how much difference that made to this particular patient. If it was somebody in their 80s, let's say.
Yeah.
I just kind of wonder whether people would have felt that motivation to kind of, like you say, go that extra mile.
Yeah.
You can always rely on the body for cynicism.
I suppose that is true. The sad thing is that you're not sure, or you feel like it would be less likely that if they were in there, if they were more elderly, but still this was quite a quick deterioration, whether, they would have got a chance for a bit more vasopressor support and a bit more time. I suppose one thing that's come out that maybe will come out of COVID and all that is that it's made people face mortality a bit more and think about death and think about the end, because we've had to deal with it so much. People who you're not expecting to pass away this year have done. So hopefully maybe it'll open a conversation a bit more nationally about planning. And I guess, escalation plans have been in the press a lot more because people have felt that they've been put in, unfairly and stuff like that. Maybe this is an opportunity for us to be able to educate patients and family a bit more.
I think the other thing I'd like to pick up on is the bit that she's really nice. It kind of, I think it links to what Polly's saying. That impact of having a nice patient, and I'm going to put a limit. Obviously, we're always nice and professional to patients, but you do go the extra mile for the ones that are nice, and I think that's okay. I don't think that makes me a bad doctor if I wanted to do extra for the patients that are nice, because that's the human side coming through. It does impact on the team being nice, and it's all those subtle little things. And as I said, we keep our professional standards up from a medical point of view, from a nursing point of view, but we're all human.
Yeah.
And actually, it's easier to go the extra mile for the nice patients, and you'll want to a bit more.
Yeah.
Whereas actually, the patient who's rude or aggressive or demanding, you probably won't go the extra mile for. You'll give them good quality care. You'll do a professional job. You won't go the extra mile. Those biases, I suppose, is the best way to describe them, do impact clinical medicine, and actually that's okay, because medicine is a human specialty. It's not a sort of mechanical thing. It's not not mechanics fixing cars. We're humans treating other humans. You hear it a lot all the time. You're seeing patients go, they're really nice. They're really sweet. I do it when I refer patients. She's a really sweet 90-year-old.
Yeah. We
just do it because I don't think it necessarily changes what we need to do, but it's just nice thing to say, I think. I'm sort of rambling on here like a fool. But.
Well, I think sometimes we do forget that we're human. Sometimes you feel like the expectation is that you're just able to deal with stuff in a slightly robotic sense, like you stay professional, you stick with your clinical judgment, and it's important not to forget that all that stuff is obviously going to be part of how you care for a patient.
I'm going to pick on the spot. Do you think ICU would have taken her if she wasn't very nice?
I honestly don't know. I don't know. It so depends on who that person is, who that consultant was on the other end of the phone that the ICU reg was talking to, I think. So I honestly don't know.
I think from my experience, they probably would, but it might take a bit longer.
Yeah.
would be putting my cynical hat on. I think it's about that sort of, we provide the professional good clinical care standard. But actually, I think because they're so nice and they're so lovely, and you get that sort of, almost X Factor style story of she's got kids and all that sort of stuff, that does impact on us, and things happen quicker.
And I think actually it's just going back to what you were saying about, I make referrals and I say, this really sweet 90-year-old. I think actually it's really important to have that kind of approach, because the other end of things is when you hear about the fracture in ED or the pneumonia, and people are labelled by their diagnosis rather than who they are or anything about them, or even their name sometimes. So I would much rather hear about, sweet 90-year-olds who have come in with such and such than, the sepsis or the sepsis.
So just to summarise, this case was a young woman with metastatic bowel cancer who unfortunately had further disease progression and was approaching the end of her life. But through, I guess, a bit of luck, through good teamwork and taking into account the sort of human impact that her case and the doctors around her took into consideration, the best outcome for her managed to come about.